as you understand your child and what you've experienced yourself with speaking and eating. And so I want it all to make sense for your experiences. And I'm really glad that Bonnie and Yulene already talked about primitive reflexes and postures and breathing, because that's going to be kind of where we start. Because if we want to speak or communicate, we have to breathe, and then we communicate on our exhale. So super important. Just a little bit about me. My name is Grace Darley. I am a speech pathologist. I have made it kind of more of a specialty to treat apraxia of speech. And then I was also recently trained to be an oral myofunctional therapist, and we'll get into what that means as well. And for anybody, just as a refresher, speech pathologists not only treat speech and language, but we can also treat cognition, voice and resonance, stuttering, feeding and swallowing, and auditory rehabilitation. So it's kind of a all-inclusive profession because all of these systems are connected. Okay, so these are the learning objectives. We're going to go over the basics of craniofacial development. When they in utero, there's the very beginning, how do we develop the face, throat, nose, mouth, and then what differences can we expect in this special population? We'll also go over the purpose of myofunctional therapy and its role in helping sleep, dental development, and speech patterns. Then we'll go over understanding what is dysarthria and what is childhood apraxia speech. These are terms that are often confusing and underdiagnosed and misdiagnosed. So we'll go over the details of that. And then lastly, just some tips for finding a provider who can meet your needs, the needs of your child, and is able to kind of think through how am I going to treat all of these systems and provide effective care. Okay, so first and foremost, the nose is for breathing. So when we think about development, we have the first breath of life through the nose. So the nose is for breathing and then smelling. The mouth is for first eating and then speaking. And so to understand complicated systems like speech, we first have to understand how do we breathe and how do we grow? How do we get food in our bodies? So for the nose, the purpose of breathing through the nose is that it filters, warms, and humidifies air to support respiration and immune function. What is it in the environment or pollution or whatever in the air and the environment that we don't want to inhale through our mouth? So our nose acts as a filter to help the immune function. It helps to regulate our nervous system. And as we know, working with occupational therapists, we need to be in an optimal regulatory state to learn. If we're hypoactive and our arousal state is too low, or if our arousal state is too high and we're hyperactive, it's not the most ideal, optimal state for learning. And then, like I said before, we also we breathe in through our nose, we exhale through our mouth for speaking. And so the inhale is shorter, the exhale is longer. For the mouth, this one is really fascinating. So they know ultrasounds that infants or fetuses begin to suck their thumb still in the womb, which is really crazy. So they have this reflex to bring the hand to the mouth, and they practice this sucking pattern in the womb. So you might see a fetus sucking their thumb or sucking their toes and preparing for breastfeeding. Swallowing is a reflex. So like we talked about, the OT and PT talked about in last session of reflexes, when we swallow, we eat, we chew, and then as soon as we take that swallow, there's nothing we can do to stop it. It's just going. And then we'll go over, so breast and bottle feeding. I know there's also some individuals who are here who did tube feeding. So whatever way, that plays into it. But so we in utero, and then we transition to breast bottle or NG tube feeding. And then we start to develop complex chewing patterns where we break down food into a small ball in the mouth, and then we transport it posteriorly down through the oral cavity. Okay, and then lastly, the OT and PT talked a little bit about proprioception, knowing where our body is in space. And to eat, we really need to know where is our tongue in space. Does it have enough range of motion to go the directions we need it to go to chew? Does it have enough coordination? Can we keep breathing or chewing? All of those systems interacting. So each of these are super important. Speech and language we're gonna get to later. Okay, so just a little bit about anatomy and physiology of the oral system. So this part, super important. This is what, all of this, when you have a sore throat and you look at your mouth, this is all red. And the palate, we can refer to as the base of the nose because it connects right with that nasal cavity. So oftentimes, if we have a wide, broad palate, we can breathe better. So this might be something that any of you can go look at your own mouth and, depending on what your breathing is like, can infer, is the shape of my palate more broad and allowing for better breathing mechanics, or is it more high and narrow, making it a little bit harder to have proper breathing? So also for the palate, this is where a lot of speech consonants come to contact. So this is going to be O, L sound. The tongue is going to come up right behind the T. T, D, N, S, Z, sh, ch, j. All of those are going to be contacting different parts of the palate. So if that palate is very high and narrow, it's going to be hard for the tongue to make those appropriate contacts. And we can get distortions or just we don't have that sound because it's tricky. We can also, so the oropharynx is the opening of the airway. This can be crowded by enlarged tonsils or a tongue height that sits higher in the mouth. A very simple way to do this, to kind of look at the oropharynx, is just to, tell your kid, say ah, shine a flashlight in there. You should be able to visualize the tonsils, the uvula, and the open airway. If the tongue is sitting higher in the mouth and you can't visualize that, that's a clue that there might be some airway restriction, might be harder to breathe. I'm sure you all have children, and I'm sure you have seen enlarged tonsils or strep throat, and those are just another way that this airway can become a little bit restrictive. And then the tongue's home, where it should rest, is right here behind the teeth on the palate. It shouldn't rest at the bottom. The resting kind of natural state where we don't have to work to maintain should be that, with the tongue up at the top of the palate. This around. This is a side cut view of the oral system, so you can kind of see the tongue, how this airway comes from the nose. This is the esophagus, the small one, and then this airway. I'm going to pass it around, so you all can take a look at that. Continue to talk. Okay. Oh, and then last thing, this, actually, it's on there. There's a structure called the vela that coordinates to the eustachian tube where we get ear infections. Children who are always chronically getting sick, always getting ear infections, it may be because there's limited movement in the oral cavity right here. And how you test for that is just open up, it should wiggle and move. If there's not much movement, the ears are not going to be draining as well. Those structures connect. And so just little clues that your doctor or pediatrician or the providers you're already working with might not be connecting. But as you piece together the clues for your own child, you can then advocate for them. And then lastly, the velum activates during non-nasal speech sounds and during the swallow. So as the little model goes around, this little, it looks like a trap door in the back of our throat. It's going to block the nasal cavity and your swallow. We don't want to probably have to send it's that little trap door that doesn't activate enough to block off the nasal cavity. We also need that working so that when we do nasal sounds, like we're allowing that air to come through our nose, right? But for sound, not nasal, every other process, we want the sound to come out of our mouth, and we need to block off that nasal path. So if we can't effectively do that, then we might get hypophonia, have enough nasal quality to our speech, or hyperbonate sound, too much air through our consonants like D, ch, all those. Any questions so far? Okay. Okay, and then as we look at the alignment of the oral cavity, we want the lips to close. The teeth are going to barely overlap, the top barely over the bottom. The tongue is resting behind the teeth, not in between the teeth or out beyond the teeth. And this is really for, if we think of the tongue and it's resting in the mouth, if our mouth is open, the weight of the tongue is pulling our jaw downward. So over time, the jaw is going to grow downward and forward instead of being more square. This is my pattern on my face, so it's more down and forward. And that, when the jaw develops like that, it can restrict the airway. Because if we imagine this kind of go like that down, we can trace it here. Now this airway is more closed. Okay, so now I kind of want to start thinking about structure, which is anatomy. We've just gone over anatomy. Anatomy is structure. Function is what are we, are we able to move the muscles and move the structure. So this is kind of like if you are part of a track team and you're doing the high jump event and you have somebody who's very petite and somebody who's very tall. Their structures are different. Their functions are going to look different. It's going to be much harder for the petite person to do the high jump. Easier for the tall person to do the high jump. But that small, the more petite person can really maximize their function, their coordination, their muscle strength. Whereas the tall person, you know, they're still going to need to do the function as well. So these are some of the things that I know about DYRK1A in terms of craniofacial development and what we can expect for functional impacts and then communication. So first of all, we know that a common characteristic in structure is a small head. This can impact brain size and the size of facial development. And then that can lead into, like I said before, the size of the palate and how well are we able to send motor signals from the brain to. Next one is a thin upper lip. This can, the functional impact is it can create weak or absent lip closure for speech, chewing, and swallowing. So as we are chewing. We should be chewing with our mouth closed. The lips are closed and they're not jamming shut. They're just kind of resting with the lips closed. And then during the swallow as well, we should optimally be able to swallow with our mouth closed. And then the communication challenge that can come along with that is absence of bilabial sound. So this might be and all three of those need both upper and lower lips to touch and hold for sound. And then in terms of eating and swallowing, if we're not able to keep those lips closed, we might have very messy eating, residue on the lip, food on the lips or the mouth. And then next one is small chin. So if we think back again to the bony structures, the chin being the bony structure on bottom and top, but in this case, the chin being the bottom. If this is smaller, that's going to have implications for the airway, the position of the jaw going down forward, and then the kind of the base of the tongue. Where is that? Does it have enough room? And often, not only in this special population, but for a lot of kids and a lot of adults, we don't quite have enough room in our mouths to effectively breathe, eat, swallow, speak. So that's something that, especially in DYRK1A, we need to think about maximizing the growth of the jaw, the whole oral facial system, but especially the jaw and the chin, so that we can support these systems. Okay. But it can also create dental crowding. So as you look at your own teeth or your children's teeth, if you're seeing a lot of crowding, too small, right? When the adult teeth came through, there wasn't enough room, and we get that crowding. And then the crowding can impact sound distortions. So, you know, sounds like S or SH or CH might be loud. Like that. The sound is pushing out toward the sides because of the dental development. So we also, structural differences in DYRK1A, weak muscles. So we might fire easily. This can be slow eating, that it's very effortful to eat. It's also very effortful to speak. And this is something that I want any therapist you work with to understand, that this is hard work for these kids. It's extremely hard. So we, need to adjust expectations, celebrate, be cheerleaders, because this is very hard work. When something is slow or labored, we know that their children are giving it their 100%. So just word on that. And then lastly, a weak muscle, a stiff muscle is a weak muscle. So we can have very hypertonic muscles where they're very spastic. And that can create limited movement. So just think of, your back pain and how that creates limited movement, and it can throw off your coordination, it can throw off your posture, it can throw off your body in space. So that's just a little bit about what structure and anatomical things we know lead into some functional impacts and what it means for communication. And once we understand this, then we can know where to go, how to effectively intervene, so that we're encouraging development of the structure and the function, not just hitting kind of these surface level skills of let's work on the S. And then if your child is showing more messy eating or chewing and swallowing signs, that's a clue to get them into feeding therapy. They'll work on the coordination of the tongue. For what the structure is, we're going to maximize the function. Okay, so we talked a little bit about resting oral posture. The mouth should be closed, the tongue is up to the palate, and we are nasal breathing daytime and nighttime unless we're speaking or taking a bite of food. So you can see this a lot in adults, but also in children. If we're breathing through our mouth at night, we're probably snoring. If we're breathing, and there's a lot of different things about mouth breathing that I think I'm going to touch on a little later, but just know that this is the optimal oral resting posture. Mouth is closed, tongue is up. And then second, then this is about oral myofunctional therapy. This is the first goal of oral myofunctional therapy, is to achieve that resting posture. The second goal of oral myofunctional therapy is to improve movement of the jaw, lips, and the tongue. This is going to be lingual palatal suction for the swallow. So lingual meaning tongue, palatal meaning the palate. The tongue is going to come up to the palate and then go backward for the swallow. It doesn't always happen that way. If we don't have suction, we'll see the tongue pushing forward in the swallow. Or if there's not good suction on the sides, we might see spillage of the water, the food we're eating, go into the cheeks. And then we also need lateral elevation of the tongue for a lot of different sounds, for R, SH, CH, J. And then we also need jaw stability for the L and the R. Lingual control. These are all the different skills that the orofacial system helps us with. So we have all this structure, our mouth, our nose, our teeth, our tongue, our breathing system, and we do breathing and eating and then speech. But if we're having a different, if there's a structural difference that is making those things difficult, it would be good to consider the structure and see what can we change or help develop. And then how can we improve the function? There's a lot we can do, especially as children and younger children as they're growing. There's a lot we can do to help them coordinate and improve the function. So, okay. And then, so I like to think of movement as strength and coordination. I am not a dancer, but if I were, if I was watching somebody dance really well and I was like, that's really cool, I would like to do that. I need enough strength if they're going to do some, I don't know, some cool move. I need the strength to do that, but I also need the coordination. And I may have one or the other, but I'm not going to be able to execute that movement unless I have both the strength and the coordination to do so. So in any kind of conversation about the function of the tongue for eating or speaking or breathing, do we have enough strength? Do we have enough coordination? Oftentimes it's both that we need to work on, both the strength and the coordination. And then this was talked about a little bit on the DYRK1A website, actually, which I was super stoked about. So going back to babies in utero, they suck, they swallow, they breathe. They suck their thumb in utero, they swallow amniotic fluid, and then they take their first breath. And this is foundational to life. And it's still present for children, adults, everybody. In terms of suck, we suction our tongue, we swallow, and we breathe. Well or not well, but we have to breathe. And then specifically for children, though, we need suction first to breastfeed. If we don't have enough suction or don't have enough support structurally in our cheeks, that suction is going to be weak. You're going to experience breastfeeding challenges, pain, or you need to transition to an NG tube, things like that. And then the swallow, we need coordination to safely swallow without liquid traveling to the airway. So like on the model that I passed around, we don't want food or liquid going up through our nose, and we don't want food or liquid going down through our airway, past our voice box. I'm sure everybody that's happened to, and we cough and get it out. So that coughing is a good thing. It's protecting your airway. But we need that coordination of these muscles in here for a good swallow to, again, protect the airway. It's all about airway, breathing. How can we protect the basics? Suck, swallow, breathe. Okay, just a few things on mouth breathing. So mouth breathing can cause dry mouth, dehydration. The tongue is heavy. The weight of it will change the structure of the jaw over time. We can get dental malocclusion or crowded teeth, teeth coming behind when they should be in front, things like that. We have increased risk of oral infections, again, because the nose is going to filter things out. So if we're breathing through our mouth, we're getting a lot of stuff right on our tonsils and right in our oral cavity filter. And then this big one, poor sleep quality. I know that there are concerns from my population about sleep, especially with relation to seizures. So sleep, another primary function of life and health. And again, a lot of kids have poor sleep, have difficulties breathing through their nose at night, getting enough good quality sleep, and not having any sleep apnea, where it's the lack of breathing is leading to oxygen loss. So if I have some resources too I can talk about, but if you suspect your child has breathing difficulties at night, I would absolutely go get a sleep study done, so you can know leading to lack of oxygen or not, just because of how important it is. But so mouth breathing can also impact oral health, gum disease, and decay, again, because the nose is a filter. If everything's going through the mouth, there's a lot of bacteria and everything's going through our oral cavity that are not ideal. And then bilabial sound. So if our posture is open mouth and we want to say mom, we have to add another step into that. We have to go close mouth, then open, then close again, and then back to an open mouth posture. Versus if we're going to say mom, but our mouth is already closed, all we have to do is start voicing mom, and then we rest here again. So in my opinion, this is just based on what my experience is, I think this is why bilabial sounds are often absent or delayed in the DYRK1A population, and they're more common. They're usually the first developing sounds, MPD, bilabial, usually the first. But that's not what I've observed with anybody who has an open mouth resting posture. Okay, these are just some quick statistics. So 85% of children with DYRK1A need speech therapy for difficulties with feeding or eating. 54% will exhibit hypotonia, muscle weakness. This relates to the diaphragm, like we were talking about earlier, this massive muscle that's here. If that's weak, it's going to be hard to exhale, to project your voice, all these things. And then it can also impact labial and lingual tongue postures. 91% have delayed absence speech. Now knowing the development and all of the sensory, motor, and visual things that you learned earlier, this makes sense. Because there's a lot of skills that lead into it. Let's see. Oh, just another word about chewing too, and eating. So when we minimally chew our food and swallow it, that can produce extra irritation in the stomach. So it's going to contribute to constipation, GERD, reflux, versus if we're really well masticating our food and chewing it very well, and there's a lot of saliva breaking it down, it's going to aid in that digestion process a lot more. Okay, now we're to speech development. Any questions so far about kind of the what comes before speech? So for speech development, it typically occurs after language development. speech development typically occurs around age 3 to 6. That's where we see more sounds coming in, more organization. And in terms of language development, we need the concept of a word to understand before we try to express it. So I need to know what a chair is. I have a concept of it. I know it can look like this or that. I have this in my head. This is language development. And then speech is, okay, how do I do my tongue and coordinate it with the breathing and what's my velum doing? Is it a nasal or non-nasal sound? Okay, I'm going to take all of that. How do I try to say that word? And then we talked also, this co-occurs with rapid changes in craniofacial development, especially dental development. So we are bringing in molars. That is a ton of development happening. We're losing teeth too. All of these things factor into what are our speech patterns. It's impacted by oral myofunctional development. So if we have limited movement in our tongue already for chewing, we can surmise that we're going to have limited movement in our tongue for speaking. And then as children go through this developmental process of age 3 to 6, we have increasing clarity of existing sounds and acquisitions of new sounds. And then by age 7, it's just the TH is what's left. By age 5, it's just the R. And so I know that this is, speech development for your children is much broader than that. But just as kind of a basis of development as a whole. And then, so as children acquire more sounds, we're going to see more immature versions of their words. The more immature versions of those start to organize and fade away. So if your child starts to say baba or bottle, they may not have a B sound, right? And so to make bottle, they're going to just repeat the B sound that they have, baba. But maybe then they have either a D sound and we get a bada. Okay, easier to understand, more variation and complexity. And then eventually we get that L, and then it sounds much more adult-like. And then I always think of what do we hear and what movement do we see? I love that OTs and PTs are so movement focused. Speech pathologists forget about that. And especially when you think about dysarthria and apraxia, you need to see how is the mouth moving? Are we overcompensating? Is the mouth moving not enough? Is it overshooting the target? Is it undershooting the target? And then how does this all come together to impact intelligibility or my ability to understand the words that you say? Okay, and then, so this is distinguishing childhood apraxia speech from dysarthria. And I go through this system by system. But first the definition. So childhood apraxia speech is inefficient motor planning and programming. This is, okay, if I want to say light, first I need to plan and put my intention, my cognition onto this part of and then my brain needs to send those signals to my mouth in a specific sequence and timing and rate to be able to make an approximation of that sound or of that word. So it's kind of like dancing, sports, music, cooking, take whatever analogy you want specific to your life. I'm going to use music. So, or I'll use dancing again. So if I want to do a dance, first I'm watching somebody do it. I'm feeling and then I need to send those signals to my limbs to try to copy it. That's the basics of motor planning and programming. With childhood apraxia speech, either or both of those gets mixed up out of order. Maybe I meant to do this action first and then this one second, but they got mixed up. Or I didn't have enough force. I needed more strength or force for this movement and it wasn't enough force. And then for dysarthria, it's more about muscle weakness and discoordination. So going back to the movement is strength plus coordination. If we have weak cheeks, or tongue, these things can impact, or we can see them in dysarthria. There's simple tests that speech pathologists can do to kind of assess the strength of these muscles, but you'll also see it in open mouth postures. You can surmise the lips are weak because they're not closing together often. They're relaxing in an open mouth posture. So going to the systems, respiration for Apraxia speech, there's not really any clinical significance, but for dysarthria, there is a lot of clinical significance. We have poor volume control, so we might be too loud or too soft habitually, or it's going to fluctuate a lot. We might have effortful breathing, so we just don't have enough breath to really sustain all the words and the exhale that we want for communication. And then we might also have changes to voice quality. So this goes back to the movement of the veil at the back of the throat. It's going to block off the nasal cavity or open the nasal cavity, depending on what sounds that we are producing. And then resonance, this leads into resonance. So with Apraxia speech, you're going to have inconsistent hypernasality. In dysarthria, you could have consistent or inconsistent hypernasality. I see more of a consistent hypernasality, but it could be either one. And then this is the most distinguishing characteristic for childhood apraxia speech is rate or prosody. This has to do with the musical aspect of communication. How does our voice rise and fall? How do we communicate emotion through our voice? And so syllable segmentation, if I was going to say banana, 3 syllables, and I'm going to chunk them like banana, and there's a little break or pause in between them. We might see lexical stress error. So if it's banana with a stress in the middle, banana, we might see a reversal of that stress pattern. So we might say banana or banana. And this can actually have a surprising effect on intelligibility. You'll see it too in dialects. So for English, like British English, some of their prosody, their lexical stress will be different. And you'll be like, wait, I don't know what you're talking about. And then you figure it out. You're like, oh, I did understand what you're saying. It was just we have a different prosody or stress pattern in our dialect. So slow rate and then atypical or reduced stress. So this might be more monotone speech, more banana. It's more flat. Okay. And then lastly, for speech articulation, we have consonants, vowel distortions, and voicing errors in both. Consonant distortions are going to be any consonant that doesn't sound super crisp. S's might be fluffy, or a T might be where the tongue is coming out of the mouth due to improper resting tongue posture. So any proper consonant, but it's distorted. Vowels are distorted. It's between 2 vowels. We can't really figure out if it's an a or eh. It's kind of in between. And then voicing errors. So a lot of consonant sounds have sister sounds. So P and B, those are sister sounds. The P sound, there's no voicing. The voice box is not moving. For a P, go towards vibrate. And so any sound that is a sister sound, we might get bat and pat. They're very similar. It's only the P and the B that's different. And if we're going to make that P or B sound in the middle, now we have an intelligibility, a communication breakdown, because we're not sure was that a P or a B because they're both words. And now I need to figure it out by context. So for dysarthria, this would imprecise articulatory contacts. It's, let me get a drink first. So this is a sciencey term, but it is what it is. It is what it says. It's so imprecise, meaning, I meant to step here, and maybe I stepped, I was close, but it wasn't like, contact was touching. And so speech is such a highly fine motor, difficult, complex skill that any small, imprecisions in your movement can have a wide impact. This can present, usually what this presents as is kind of slurred speech, where consonants are kind of running into each other, things like that. And then back to apraxia, intrusive schwa. This is going to be an extra We have the answer. Okay. This is an extra usually at the end of words. So if it's mine, we might see mine. We get that extra consonant or extra at the end of a word. Articulatory groping. This is, I'm trying to figure out how to put my tongue in my mouth in the right spot for that word. So if I'm going to say shoe, I might go shoe. So I'm kind of searching. You can see my mouth kind of figuring out where to go. Similar if you were in a dark room and you're kind of not quite sure where things are, just, trying to figure out the path. You'll see increased difficulty with multi-syllable words. It's a marked increase. We know that they're, just as children develop, multi-syllable words are going to be more difficult, but it's going to be, avoidance of multi-syllable words or a marked decrease in intelligibility for those multi-syllable words. And then difficulty with initial articulatory configurations. This is having difficulty getting started in a word. Similar to the articulatory groping, it's where do I start? What space do I need to move my mouth into to be able to produce the word? Okay, and then just some tenets about looking for a provider and some treatments that are specific to apraxia speech and childhood dysarthria. Yes, dysarthria. So typically they're high intensity, 30-minute sessions, 3 times a week. That's what the research says for these populations. However, the DYRK1A population haven't been studied in specific to this population. So we are using the research we know and trying to apply it to this population. We do draw from the studies and research in Down syndrome. A lot of children with Down syndrome have dysarthria as a primary speech diagnosis. Sometimes apraxia too, but primarily dysarthria in that weakness, that weak tone. And then this is my most, this is what I would recommend for anybody doing with dysarthria and apraxia. There's some other ones out there, but this is the one that has the best research and is appropriate for children who are more limited in their speech and need more. And all this method is doing is providing the child with the right amount of support that they need. So if we're going to work on something super simple like hi, and we're just going to work to shape an H sound to a vowel, that's what we're going to work on. Other children I worked with, we're doing forceful work, and we're sequencing it much more complicated. So it's scalable. This is one that is for adults with Parkinson's and dysarthria. It's a breathing one. Again, not something that I think would be as beneficial, but I like that it incorporates the breathing aspect to it. And then the speech therapist should give you a combination, should be using a combination of verbal, visual, tactile, kinetic cues. I don't really like prompt therapy. You might have heard that one, BRO CCC, because it's very heavy tactile cues. A lot of speech pathologists don't like kids' faces that much. Kids don't like speech pathologists to do their faces that much. And it's just one of several cues that we could employ. And I'm going to do whatever cue is best for that child at that moment in that word. I'm going to be able to flex my cues to meet the needs of the child. So, and then I'm going to keep going. Let's see. And then these are just some resources for how to find providers looking specifically for apraxia and dysarthria. Apraxia Kids and Childhood Apraxia Treatment, the Once Upon a Time Foundation, they both have registries of people, of speech pathologists who have taken extra courses in these topics. It's kind of an unfortunate reality that oral myofunctional therapy and dysarthria and apraxia were not really a part of our training in graduate school. We got like maybe a couple hours on it. It's very limited. And I think it's changing now, but so don't assume that your speech pathologist knows these. They have not been in there. It's okay to ask them what courses they've taken. It's okay to, and if they're not willing to answer your questions, that's a signal. And they should be willing to learn and do some research, develop some skills to meet the needs of your child. For feeding, the SOS, they have a registry. This is another continuing education course that's popular for feeding. And then there's not really any registries for ENTs, dentists, or myofunctional therapists, but these are some training groups that are more vetted. So you might ask, you know, what additional training have you done for myofunctional therapy, or what additional continuing education have you done in dysarthria? And they might, you know, they might relate to one of these courses. Okay, and then just some general guidelines about finding a therapist. Can your therapist explain what they're doing and why? I want a therapist to stop me at any time and say, what are you doing? And I can say, oh, this is what I'm doing. You know, I am working on pi because we don't have any. It's a simple syllable structure. The child is successful with it. It has social implications. This is why. Right now. If they don't know, either they don't know themselves, or maybe they're, I don't know. So what is the therapist doing and why? Even for assessment. And why is it appropriate for my child? For example, a single word naming test, where I'm asking a child to name something on a picture. It's not going to give me much information if I give this to a child who is minimally verbal. It's going to provide almost no information. If a child is speaking in 3 to 4 word sentences, this is going to give me a lot more information. So, and then is your therapist following a checklist or a set program for your child? A lot of times, providers can fall into a trap of, this is your 12-step program. Boom, 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 boom. We go through that and then you're done. And the body and the mind and different syndromes or sequences are much more individual and complex than that. And so we need providers who are able to customize. Oh, they're all number 1. They're all very important. How do you measure progress? How often are you evaluating? School districts will often evaluate every 3 years, which is a long time. A lot of skills should have occurred. And so I reevaluate much sooner because I want to know, did I go for result on the rotate? If yes, I have more track, I'm going to keep going. If no, what do we need to do? Is there an occupational therapy or physical therapy referral that needs to be made? Do I need to change my treatment method? Do I need to incorporate another system? Do I need to work more with the training family to do homework? So it's good to know where we are at with progress. And then does your therapist encourage you to be part of the decision-making therapy process? It's my hope that in this conversation, you all were able to recognize, like, oh yeah, okay, I've observed that, or, okay, that makes sense for what I've experienced in my body or seen my child experience through this in speech or language or anything or whatever. So you have a lot of intuition and wisdom, and the therapist should absolutely be bringing in that and considering that and what's important to you and your family and how can we, have parents be our therapeutic partners. Okay, and that's just the recap: craniofacial development, myofunctional therapy, dysarthria versus CAS, and then tips for primary provider. Questions?
Let me grab the mic. Wait, let me grab the mic. Good. If we can try to hold our questions so I can get the mic to you, so the people that are remote can hear the question and also so you can hear it too. Question from Eric. What are your suggestions if prompt is recommended?
First, I would ask, why are you recommending that? I would ask the therapist to justify their thinking. Why did you think this was the best method? And ask it one more time.
What is your suggestion if prompt is recommended?
You could either find dynamic temporal concept viewing, or go into it knowing the research is not as strong for prompt. So I'm willing to go forward with it, but I'm gonna monitor to see if it's working as I expect it to. And especially with prompt, we want to fade, and in any method, we want to fade out cues as long as they're no longer needed. So think about training wheels on a bike. As soon as they're no longer needed, you gotta take them out. And one of the risks with prompt is that the tactile cues are not faded as much. So I would just monitor, if you're gonna do it, I would monitor and see if I'm able to start fading out the tactile. I'm seeing these skills at home when they're not. Hopefully that answers it.
Can I? I'll come up to the mic. I just wanted to get that. So prompt worked really well for me. And I don't know if the DYRK1A community is it because prompt is so that they give tactile cues to make something. One like even B is book, even G is good. So it's not always exactly the same. So physical touch is really good for him. And I noticed that through his life. I would say which toy do you want? He would put in the paper that I put my hand on his hand, then he would move his hand. So with DYRK1A, I think sometimes maybe the physical thing is good, but I get it about the way.
Yes, and tactile cues are absolutely good. But they're only one cue in a whole basket of cues you would get, right? But yes, I would definitely, and I have used that with, we're gonna say pop, we're gonna blow bubbles and say pop. I have used, that tactile cue, let's close those lips, open, close, because we know that when we move, not just our mouth, but when we move our body, our fingers in touch cues, bridging those muscles together. So yes, great comment that
It worked for us when we did.
yeah.
And the next question, is overall design forward under insurance?
No, they don't. Well, there's a way around it.
Is oral design forward under insurance?
Yeah, so is oral myofunctional therapy covered under insurance? Unless the therapist is going to bill or code it as swallowing, they will pay for swallowing. It doesn't matter. Insurance doesn't want to pay for developmental things, but they will pay for medical things, especially in this population where it's violent. If we can get the providers to understand about billing for swallowing foods, then that's right.
What are some early indicators that speech therapy may be appropriate?
Great question. First, in infancy, if the child's not babbling, that's going to be your first sign that they're not exploring sound. Any sort of early feeding, flat, difficulty breastfeeding, and children go through any of that is sending a signal that I don't have good control of my tongue. I've got structural things going on and early functional things that get difficult.
Anyone?
Who else?
Yes. Research report working on the OTC code, if they get that, we put that out. It's not, it's so, yes, same here. I think she's the expert on that. She was asking about the OTC code of that. Oh, I was wrong. And I see your age. They're working on. So I think that's the code that actually defines the diagnosis specifically. Correct. So it would be a code that, so when you go to the doctor, they give you all your codes for all your stuff. We don't have them for DYRK1A yet. So that's what they're, like, we have the data and research enough people with DYRK1A to make it an official diagnosis code. And the doctors can go in and type it in and look stuff up and add it for like insurance and stuff, right?
The treatment code that you should look for, it's called dysphagia, dysphagia. That's the thing. And there's different codes for dysphagia, oral things, which is mouthful, get compared to, and then there's different codes for dysphagia, esophageal. That's like things that documented, and it's terrible, you know. So there's different dysphagia codes based on what you're doing, but really it's the oral phase dysphagia code that you need to build for working in the mouth. Yeah, and it's not just we're going to bite on these chewy tubes and bite and chew that. It's not that. That's just going to tense up people. So again, anything complicated. And coordinate breathing. Think whole system. Other questions?
I have one. Is there a simple way to encourage non mouth breathing?
There are things. So I first figure out why are you not breathing because are we? Are you not breathing because they're upward? Not breathing because I'm super congested and I have a breathing. So I would go through your channels. With the most sensitive are not trained on speech. They are structuralists. They look at the structure, you know, your sentence is straight. You know, they don't. If we're not breathing where the function isn't happening. So I first and see rule out and then functionally, you can assemble. I started doing it. There's a balance that you can go around this. And it's kind of like you say, take a fossil. I'm gonna do it. I have to just so here's around this, and just for these lips to engage and work, and to keep that mouth closed during sleep. I would not but it's one simple thing that
Was it called?
I don't. It is simple. mouth tape,
Okay.
and but it's just if you don't tape, athletic tape, have to be really small sizes, and it goes right to